Welcome to the Deep Dive. We're here to take complex, really high-stakes medical information and turn it into knowledge you can absolutely rely on. Today, we're tackling skeletal muscle relaxants, SMRs, and our mission really is mastery. This is an intensive look, source by source, treating this like, well, the most critical study material you'll encounter, because in practice, there's just no room for error with these drugs.
That's exactly the right way to think about it. Skeletal muscle relaxants. They manipulate muscle tone, muscle function, but through entirely different routes. So first step, always, is categorization. Where do they act? Is it peripheral, out at the neuromuscular junction, the NMJ, or maybe the modal fiber? Or is it central, working within the spinal cord and brain?
Right, and that location dictates everything. Peripheral action. That means we're mostly talking about neuromuscular blocking agents, NMBs.
Precisely. NMBs are about causing complete controlled paralysis. I mean, they're indispensable tools for modern general anesthesia. You need them for tracheal intubation, for getting that totally relaxed surgical field, think abdominal or thoracic surgery. But because they stop breathing, well, your control over them has to be absolutely perfect.
Okay, then you have the other group, the centrally acting SMRs, KMRs you call them. Different goal altogether.
Totally different goal. These modulate tone. They're aimed at treating painful muscle spasms or managing spasticity in neurological conditions like multiple sclerosis, maybe dealing with acute injuries. The key is they do this without causing that total paralysis.
It's clear the clinical need is huge for both. But the NMBs, the pharmacology sounds like it needs a really deep dive. History, chemistry, the works.
It absolutely does. The history itself is fascinating.
All right, let's unpack that. Let's trace where these peripheral blockers came from. And that story, well, it starts with something ancient, almost mythical.
Yeah.
Curare.
Yeah, curare. It's not one single thing, actually, more a collective name for various plant extracts from South America. Things like Strychnos toxifera, Chondrodendron tomentosum. For tribal hunters, it was genius. An arrow poison that caused complete paralysis, it immobilized the prey. But crucially, it didn't kill instantly. The meat was still safe to eat. The key active compound they eventually isolated was D-tubocurarine, or DTC.
It's kind of wild to think this hunting poison becomes the basis for modern anesthesia.
Yeah.
But the big leap in understanding, that came later, right? Claude Bernard, 1856.
Absolutely. Bernard's experiment wasn't just about finding a drug. It was about proving the neuromuscular junction even existed as a distinct place where drugs could act. Revolutionary stuff.
How did he actually do it? The setup was pretty clever, wasn't it?
Deceptively simple, really. He used a pithed frog, basically, removing the brain and spinal cord influence. He'd stimulate the sciatic nerve and watch the leg muscle contract. Standard stuff. Then, he injects curare. Muscle stops responding to the nerve stimulation. Okay, but here's the genius part. He tried ligating, tying off the blood supply to one leg before injecting the curare systemically. And guess what? That leg's muscle kept twitching when the nerve was stimulated.
Ah, so the drug had to travel through the blood. It wasn't acting on the nerve directly, or the CNS.
Exactly. It ruled out the CNS and the nerve itself. Then he went further. He showed the muscle itself was still fine. Stimulate the curarized muscle directly, it still contracts. Soak the nerve in curare, it still conducts signals. By elimination, the only place left was that tiny gap, that connection point between nerve ending and muscle fiber, the muscle end plate. That became the target.
Amazing. And that knowledge from a frog experiment eventually leads to DTC being used clinically in the 1930s. And that kicks off the search for synthetic versions, right? Like succinylcholine. Things may be more controllable.
Precisely. Better control, fewer side effects, better cardiovascular profiles. That was the goal. Okay, so let's look at that first class of modern NMBs.
Yeah.
The competitive or non-depolarizing blockers. We're talking DTC originally, but now things like vecuronium, rocuronium, pancuronium, their whole game is physical competition. They fight with the body's own neurotransmitter, acetylcholine ACA, for a space on the nicotinic cholinergic receptors, specifically the NM subtype, right there at the muscle end plate.
And this is where that great term comes in. Bovet, 1951. Patch curare.
Yes, pachycurare meaning thick curare. They are physically large, bulky molecules. Chemically, they're drawn to the receptor site, usually because they have two or more quaternary nitrogen atoms, those positively charged nitrogens, high affinity. But, and this is the absolute key, they have zero intrinsic activity. They are pure antagonists.
They fit the lock, but they can't turn the key. And the lock itself, the NM receptor, it's quite a machine, isn't it?
It really is elegant. It's a protein complex, 5 subunits, usually 2 alpha, 1 beta, 1 epsilon or gamma, and 1 delta, all arranged to form a central pore, which is a sodium channel. Reishi binds to those two alpha subunits. That binding causes this tiny essential conformational shift, like a little molecular twist, that opens the channel. Sodium rushes in, creates the end plate potential, the EPP. But when a big, bulky pachycurare molecule sits there, it physically blocks that twisting motion. No channel opening.
And if that EPP doesn't hit the threshold needed to trigger the surrounding voltage-gated sodium channels, no muscle action potential travels down the fiber. Result: flaccid paralysis.
Right. And the clinical advantage of this pure competition is reversibility. Because it's just a numbers game at the receptor, you can overcome the block by increasing the concentration of the natural agonist, HEH. In the OR, we achieve this by giving anticholinesterase drugs, like neostigmine. They stop the breakdown of the HE that's already there, effectively flooding the junction.
Okay, simple competition. But you mentioned it gets more complex. High doses, for instance.
Yeah, at very high concentrations, these competitive blockers aren't purely competitive anymore. They can actually start to directly block the open sodium channel itself. That's a non-competitive action. It means that really deep block isn't fully reversible just by adding more HHS. Neostigmine only partially works then.
And the other layer of complexity, projunctional blockade. This explains that fade thing we see in monitoring.
This is absolutely critical for real mastery, yes. Competitive blockers don't just bind to the post-junctional receptors on the muscle. They also bind to nicotinic receptors located on the nerve ending itself. Normally, AT binding to these projunctional receptors helps mobilize more AT vesicles ready for release, especially when the nerve is firing rapidly. It's like a feedback loop to maintain supply. When you block these projunctional receptors with a competitive NMB, you interfere with that mobilization process.
So, if you stimulate the nerve repeatedly, say with a train of 4, the amount of HE released with each subsequent pulse drops off faster because that backup supply isn't being mobilized properly.
Exactly that. The readily available pool gets depleted, and the reserve can't be brought up quickly enough. That failure is what causes fade, the progressive weakening of the muscle twitches during repetitive stimulation. It's a hallmark of competitive block.
And the flip side of that is post-tetanic potentiation, PTP.
Right. PTP happens right after you hit the nerve with tetanus, a really fast burst of stimulation.
Yeah.
That intense activity causes this temporary surge in calcium influx presynaptically, which overcomes a mobilization block for a moment, leading to a big release of ACT. So if you give a single twitch stimulus immediately after the tetanus, the response is surprisingly strong, stronger than before the tetanus. Seeing PTP tells you there's a partial competitive block present.
Okay, switching gears now to the other chemical class, the depolarizing blockers. Succinylcholine, SCHE, is the main one we use, also decamethonium historically, and Bovet called these leptocurare.
Leptocurare, slender curare. Unlike the bulky pachycurare, these are long, thin, flexible molecules. They also usually have 2 quaternary nitrogens, so they bind to the NM receptor. But here's the massive difference. Leptocurare have affinity and intrinsic activity. They act like yachari, they bind, they cause that conformational change, they open the sodium channels, and they depolarize the muscle membrane.
Which explains the initial muscle twitching, those fasciculations you see right after giving ESHA. It's actually activating the muscle briefly.
Exactly. But the problem is, unlike HE, which gets broken down almost instantly by acetylcholinesterase at the end plate, HAC isn't. It hangs around. This prolonged presence leads to prolonged depolarization, and that sets up the 2 distinct phases of its block.
Let's start with phase I, the classic depolarizing block.
Phase I is fast, very fast onset. The muscle membrane potential drops because of that persistent channel opening, down to maybe mid at 50 millivolts instead of the resting at 90. At that less negative potential, the voltage-gated sodium channels nearby, the ones responsible for propagating the action potential down the muscle fiber, become inactivated. They can't reset. This creates a band of inexcitability around the end plate. No action potential can get through. Result: flaccid paralysis, in mammals anyway.
And the clinical features of phase I are basically the opposite of competitive block. Getting this straight is vital.
Absolutely mission critical. In phase I, the block is not reversed by anticholinesterases like neostigmine. Why? Because adding more agonist to an already depolarized membrane just makes the depolarization worse, or at least doesn't help repolarize. Also because the projunctional AC mobilization isn't blocked in the same way. If you stimulate tetanically, the response is sustained. There is no fade, and therefore there's no post-tetanic potentiation either. The train of 4 ratio stays stubbornly at 1.0, even though all 4 twitches are significantly weaker than baseline.
But if the SG hangs around too long or the dose is very high, things can change into phase II block.
Yes. Phase II, sometimes called desensitization block. This develops more slowly. What happens is complex, but essentially the receptors become desensitized, less responsive, even as the membrane potential starts to creep back towards normal, repolarizing somewhat. And here's the tricky part. Physiologically, phase 2 starts to look like a competitive block. Recovery becomes slow. Tetanic stimulation does show fade now. And critically, the block becomes partially reversible by anticholinergics.
So a patient who should have recovered quickly from SG but remains paralyzed for hours, you have to suspect they've drifted into phase 2, which sounds like a management nightmare.
It can be. And certain things make phase 2 more likely. The big one is atypical or deficient plasma pseudocholinesterase, the enzyme that normally breaks down SG in the blood. If that enzyme doesn't work well, SG levels stay high, pushing the patient into phase 2. Also, concurrent use of certain inhaled anesthetics, the fluorinated ones, seems to predispose to phase 2 development as well.
Okay, let's talk practicalities. The order muscles get paralyzed matters, especially for airway safety. With the competitive, non-depolarizing blockers, what's the typical pattern?
It generally follows muscle size and metabolic activity. Small, rapidly contracting muscles go first. Think fingers, muscles moving the eyes. Then it spreads to the limbs, the trunk, the intercostal muscles involved in breathing, and the diaphragm is usually the last muscle to succumb. This gives a bit of a safety margin for managing ventilation.
And recovery. Just the reverse.
Exactly reverse, thankfully. The diaphragm recovers function first, then intercostals, trunk, limbs, and finally the small muscles. That's why we often assess recovery by looking at things like head lift or hand grip strength last.
The style of the depolarizer is different, though. Much faster.
Oh, it's lightning fast. Apnoea cessation of breathing happens within, say, 45 to 90 seconds. And if the patient has normal enzymes, recovery starts in just 2 to 5 minutes. The sequence is maybe a bit different in neck and limbs than face, jaw, eyes perhaps. But honestly, it happens so quickly it feels almost simultaneous. Complete paralysis very, very rapidly. Hashtag 2.2, monitoring neuromuscular blockade. The elite detail.
Right, this monitoring section. You said this is where we get into elite detail. Why is just watching for movement or checking a single twitch not good enough?
Because a single twitch only tells you if some connection is happening. It doesn't tell you about the reserve at the neuromuscular junction, which is what fails first and what determines if the patient can actually sustain breathing. We need to challenge the NMJ, see if it fatigues.
And that's where the train of 4 TOF comes in, the standard.
It's the gold standard, yes. We use a nerve stimulator, usually on the ulnar nerve at the wrist watching the thumboduct, or the facial nerve watching eyebrow movement. We deliver 4 quick electrical pulses over 2 seconds. It's 2 hertz frequency.
And you're comparing the twitches, specifically the last one to the first one.
Exactly. We look at the height or strength of the 4th twitch, T4, compared to the first twitch, T1. That ratio, T4-T1, is the TOF ratio. With a competitive blocker, T1 is already reduced because receptors are blocked, but T4 is reduced even more because of that projunctional fade mechanism we discussed. So the TOS ratio drops significantly below 1.0. Clinically, we generally want to see that ratio recover to at least 0.7, ideally 0.9 or higher, before we're confident the patient can maintain their own airway and breathing adequately.
But again, for SG in phase 1, the ratio itself doesn't tell you much.
Correct. In phase I depolarizing block, there's no fade. All 4 twitches are equally depressed, so the TOF ratio stays 1.0. Seeing a ratio of 1.0 but with weak twitches points towards phase 1. Only if it transitions to phase 2 will you start seeing that ratio drop below 1.0. Critical distinction.
We also use the number of twitches present to gauge recovery depth, right? Before giving reversal agents.
Yes. If you can only see one twitch, T1, the block is very deep, maybe 90-95% receptors still blocked. If the second twitch, T2, reappears, that's better, but still maybe 90% block. Getting the 4th twitch, T4, back is a key milestone, suggests maybe 75% block or less remaining. You typically need at least T2, preferably T3 or T4, visible before giving neostigmine effectively.
And there are other ways to stimulate besides TOF. Tetanus.
Catanic stimulation, hitting the nerve with a very fast pulse train, like 50 or 100 hertz for 5 seconds, is a powerful way to check for fade. You see if the muscle contraction holds strong or visibly weakens during the tetanus. It's quite uncomfortable for an awake patient, though.
Is that why double burst stimulation, DBS, was developed?
Partly, yes. DBS is less painful and maybe easier to assess fade by feel, especially during recovery. It involves 2 short bursts of high-frequency pulses, usually 3 pulses each, separated by about 3/4 of a second, 750 meters. You compare the strength of the response to the second burst versus the first. If the second is weaker, fade is still present.
And one more, post-tetanic count, PTC. When is that used?
PTC is for when the block is so deep that you get no response to TOF, or even single twitches. 0 twitches. To get some idea of how deep, you apply tetanus for 5 seconds, wait 3 seconds, and then start giving single pulses again, counting how many twitches you can elicit before it fades out again. A PTC of 0 or 1 means a very, very profound block. A higher count, say 5 or 6, means it's starting to wear off, and reversal might soon be possible. It helps guide timing. Hashtag 2.3 systemic actions and side effects.
Okay.
Important point. These drugs aren't perfectly selective for the NMJ. Because acetylcholine is used elsewhere, NMBs can have spillover effects, especially on the autonomic nervous system.
Starting with the autonomic ganglia.
Right? Ganglia use nicotinic receptors too, the NN subtype. Older competitive blockers, particularly D2-curare-derived, were notorious for also blocking these ganglionic receptors. That ganglionic blockade leads to vasodilation, drop in blood pressure, unwanted side effects. Huge advantage of the newer agents, vicuronium, rocuronium, cisatracurium, is their high selectivity for the NN receptor. They have minimal to negligible effects on ganglia.
ESH, though, being an agonist, it stimulates ganglia.
Yes, it does. It can activate both sympathetic and parasympathetic vagal ganglia. This leads to unpredictable effects on heart rate and blood pressure, sometimes slowing, sometimes speeding up, sometimes raising pressure. It's messy.
Okay, next big side effect, histamine release. The reason DTTs basically vanish.
Pretty much. DTC was the worst offender, rated +++. It triggers histamine release directly from mast cells, not through an allergic mechanism, just due to its chemical structure. And histamine release in an anesthetized patient is bad news. Profound hypotension, skin flushing, potentially severe bronchospasm, increased airway secretions. Atracurium and its relative mavicurium still have a small potential plus, which is why cisatracurium, the isomer of atracurium, was developed. It has virtually none. Important to note, heparin can sometimes be co-released with histamine too.
So pulling the cardiovascular effects together, it really varies by drug.
Hugely. DTC. Big drop in BP from ganglionic block and histamine, maybe reflex tachycardia. Pancuronium, another older long-acting drug, is different. It often causes tachycardia and a rise in BP.
Why does pancuronium cause tachycardia? That seems counterintuitive for a blocker.
Good question. It's not from nicotinic effects. Pancuronium has significant antimuscarinic activity, specifically blocking M2 receptors on the heart. It inhibits the vagus nerve slowing effect on the heart rate. We call it a vagolytic effect.
So it takes the brake off the heart rate?
Okay.
But the newer intermediate drugs are much cleaner.
Much cleaner. Vicuronium, rocuronium, cisatracurium, they are prized for being cardiovascularly stable. Minimal effect on BP or heart rate. That's why they're often the go-to choices, especially in sicker patients.
But the most feared cardiovascular event is still with SG, isn't it? Hyperkalemia.
Absolutely. This is the non-negotiable danger zone. SMISH causes muscle cell membranes to leak potassium ions into the bloodstream. In a normal, healthy person, serum potassium might rise by maybe 0.5 milli-DQL, usually not a big deal. But in patients with massive burns, crush injuries, spinal cord injuries, prolonged immobility, or certain neuromuscular diseases, these conditions cause an upregulation of extrajunctional SME receptors all over the muscle membrane. Give SME to these patients, and the potassium efflux is massive, potentially causing life-threatening hyperkalemia and cardiac arrest. It's an absolute contraindication in those situations.
And just to reiterate, these are all quaternary ammonium compounds, charged molecules, that means.
It means they don't easily cross lipid membranes, they don't cross the blood-brain barrier, so no effect on consciousness, and they don't cross the placenta in significant amounts, which is important in obstetrics. Hashtag 2.4 pharmacokinetics and drug specificity.
The duration of action for the competitive NMBs seems directly linked to how they're eliminated. That determines if they're long, intermediate, or short-acting.
Largely, yes. The long-acting drugs like pancuronium, DTC, joxicurium, their duration is over 60 minutes, often much longer, because they rely heavily on the kidneys for excretion. So if you have kidney failure, these drugs hang around dangerously long. The intermediate acting, around 20-40 minutes, and short-acting drugs, vicuronium, rocuronium, atracurium, cisatracurium, mivacurium, depend more on metabolism, liver or plasma enzymes, or redistribution away from the NMJ to terminate their effect initially. Renal failure has much less impact on their duration.
ACE is ultra-short, 5 to 8 minutes maybe, but its breakdown depends entirely on one specific enzyme system, which can be faulty.
Right. ESH isn't broken down by the acetylcholinesterase at the NMJ. It's hydrolyzed out in the plasma by a different enzyme called pseudocholinesterase, or butyrylcholinesterase. The problem is there's significant genetic variation in this enzyme. About 1 in 3,000 people are homozygous for an atypical, poorly functioning version of the enzyme. In these individuals, ESH isn't broken down quickly. It sticks around, pushes them into that prolonged phase 2 block, and they can remain paralyzed and apneic for hours, needing prolonged ventilation. It's a major hidden risk.
That risk must drive a lot of the interest in alternatives. Okay, let's talk about a really unique elimination pathway that gets around kidney and liver issues, Hoffman elimination.
Hoffman elimination. It's chemically fascinating. Atracurium, an intermediate-acting drug, uses this. Part of its breakdown happens spontaneously in the plasma at physiological pH and temperature through this non-enzymatic chemical degradation. It also gets partly hydrolyzed by esterases. The beauty is this Hoffman elimination is independent of organ function. So atracurium's duration is pretty reliable even in patients with severe kidney or liver failure. Great for the ICU. The slight catch with atracurium is one of its breakdown products, lodanosine, which can cross the blood-brain barrier and potentially cause CNS excitation or seizures if it accumulates during very long infusions.
Which led to cisatracurium, the refined version.
Exactly. Cisatracurium is one specific isomer, a stereoisomer of atracurium. It was selected because it undergoes Hoffman elimination almost exclusively with minimal enzymatic hydrolysis and minimal hepatic metabolism. This means less lodanosine production, making it safer for long infusions. Plus, it has the added benefit of causing virtually zero histamine release and being very cardiovascularly stable, often considered the top choice for infusions in critically ill patients or those with organ failure.
Let's quickly recap the key players then. Why do we still use acerate with all its documented risks?
Speed and predictability in most people. Nothing else provides such a rapid onset, 1 to 1.5 minutes, profound paralysis, and rapid spontaneous recovery, 5 to 8 minutes. For emergency intubations or very brief procedures where you need intense relaxation now and want it gone quickly, it's still often the fastest tool.
But if ESER is too risky, say because of hyperkalemia concerns, the go-to rapid non-depolarizing alternative is rocuronium.
Yes. Rocuronium has the fastest onset among the currently available non-depolarizing agents. At higher doses, around 1.0, 1.2 millijoule kilogram, its onset time approaches that of ESI, maybe 1-2 minutes, allowing for rapid sequence induction without the depolarizing risks. It's mainly eliminated unchanged in the bile, with some kidney excretion too.
And if you need the shortest duration competitive block?
That would be my Vicurium. Its duration is typically only 15-30 minutes because, like ESI, it's rapidly metabolized by plasma pseudocholinesterase. So it offers a short competitive block, but you still have that small risk of prolonged paralysis if the patient has deficient enzyme activity, though without the hyperkalemia risk of ESI.
Okay, interactions. Crucial in anesthesia, where multiple drugs are always used. General anesthetics themselves make competitive blockers work better, right?
They do potentiate them, meaning you need less NMB to get the same effect. The mechanisms are complex anesthetics, might depress CNS drive to muscles, maybe stabilize the muscle membrane slightly, enhance receptor affinity, or decrease nerve excitability. Historically, ether was the most potent potentiator. Of the modern inhaled agents, the fluorinated ones like isoflurane potentiate significantly, more than desflurane or sevoflurane. Halothane and nitrous oxide have the least potentiating effect.
And those fluorinated anesthetics, they have that double danger with SK we mentioned.
Right. They increase the chance of SK causing phase 2 block. And critically, the combination of SK plus a fluorinated agent is the classic trigger for malignant hyperthermia in susceptible people, a deadly interaction.
Antibiotics, too, some of them can cause problems with NMBs.
Yes, definitely. The aminoglycosides gentamicin, tobramycin, amikacin are the main culprits. They significantly potentiate competitive blockers. Their main effect seems to be projunctional. They interfere with calcium influx into the nerve terminal, which is necessary for ADC release. So less AC gets released with each nerve impulse, making the competitive blocker more effective. Other antibiotics like tetracyclines, clindamycin, polymyxins can also potentiate NMBs to varying degrees, something to always check for.
And even common cardiac drugs or electrolyte issues.
Calcium channel blockers, like verapamil, can potentiate both types of NMBs, likely by interfering with calcium's role at the nerve terminal and possibly muscle. And low potassium levels, hypokalemia, often caused by diuretics, definitely enhances the effect of competitive blockers. The muscle membrane is hyperpolarized slightly, making it harder to depolarize, so the blocker has an easier job. Hashtag 3.2 reversal agents.
Residual paralysis after surgery is a major risk for breathing problems, so actively reversing competitive NMBs is standard practice, unless the block has clearly fully worn off. The traditional way is with anticholinesterases.
Correct. Neostigmine is the workhorse. Its job is simple. Inhibit the enzyme acetylcholinesterase, which breaks down HEE. By inhibiting the enzyme, HEE levels build up significantly at the NMJ. This high concentration of HE then successfully competes with the NMB molecules still lingering on the receptors, restoring transmission.
But neostigmine isn't selective just for the NMJ enzyme. That causes side effects elsewhere.
Exactly. It boosts HE levels at all cholinergic synapses, including muscarinic ones in the heart, lungs, gut, glands. This causes the classic muscarinic side effects: bradycardia, slow heart rate, hypotension, bronchoconstriction, increased salivation, and bowel activity. To counteract these potentially dangerous effects, you always have to give an anti-muscarinic drug, usually atropine or glycopyrrolate, either just before or mixed with the neostigmine.
Then came Shigamadex, a totally different way to reverse.
Completely different paradigm. Shigamadex is specifically designed for reversing the steroidal NMBs, rocuronium and vecuronium. It's a modified gamma-cyclodextrin, which sounds complicated, but think of it as a donut-shaped molecule, an encapsulator. It doesn't interact with HE8 or any receptors. It floats around in the plasma and directly binds to free rocuronium or vecuronium molecules, trapping them inside its structure like a key in a lockbox. This forms a very stable, inactive complex.
So it just physically removes the blocker from circulation.
Precisely. As free drug is removed from the plasma, the equilibrium shifts. More blocker molecules detach from the NMJ receptors to replenish the plasma levels, and they too get immediately captured by Succinylcholine. The result is incredibly rapid and complete reversal of the block, usually within 2-3 minutes, even from profound levels of paralysis. And because it doesn't involve the cholinergic system at all, you avoid all those muscarinic side effects. No need for atropine or glycopyrrolate. It's a game changer, especially for deep blocks or when rapid reversal is critical. The complex is then simply excreted by the kidneys. Hashtag 3.3 toxicity and complications.
Let's just quickly summarize the biggest dangers, most important toxicities to remember. Top of the list.
Has to be respiratory paralysis and prolonged apnea. If the block isn't reversed properly or wears off slower than expected, the patient can't breathe. Requires constant vigilance and ventilatory support.
And the cardiac risks, primarily with SG again?
Yes, that hyperkalemia risk in susceptible patients leading to arrhythmias or cardiac arrest is paramount. Also, remember the less specific cardiovascular effects. Hypotension from histamine release, DTC, etricurium, mavacurium, or the variable effects of SG on heart rate and BP due to ganglionic stimulation.
And the other potential issues.
Flushing from histamine release. Precipitation of asthma, again from histamine. That annoying postoperative muscle soreness often seen after SG due to the initial fasciculations. And of course the rare but catastrophic risk of triggering malignant hyperthermia, especially SG with volatile anesthetics. Hashtag 3.4 clinical uses of NMBs. Where do we actually use these? The number one use by far is as adjunct to general anesthesia.
Right, to get that muscle relaxation needed for surgery without having to use dangerously deep levels of anesthetic gas or IV agents.
Exactly. Allows surgery on the abdomen, chest, delicate orthopedic procedures, eye surgery. It also makes tracheal intubation much easier and less traumatic. The choice of agent depends on the needed duration and the patient's condition. For longer cases, intermediate agents like vecuronium, cisatricurium, rocuronium are often preferred for their stability. For very fine work like eye surgery, competitive blockers are good because they reliably paralyze those small muscles.
And SC still has its niche for speed.
Absolutely. Rapid sequence intubation in emergencies, short procedures like setting a fracture, laryngoscopy, bronchoscopy, where you need it fast and gone fast.
What about outside the operating room, in the ICU?
Yes. Continuous infusions of competitive blockers, often vecuronium or cisatricurium because of their stability and metabolism, are used in the ICU. This helps patients tolerate mechanical ventilation better, reduces oxygen consumption by stopping shivering or fighting the ventilator, and can help manage severe ARDS sometimes. Careful monitoring and awareness of potential accumulation, especially of metabolites with long infusions, is key.
And one other specific use, electroconvulsive therapy, ECT.
Right. To prevent the intense muscle contractions and potential injuries like fractures or dislocations associated with the induced seizure, a short-acting NMB, usually SEGS or sometimes mivacurium, is given just before the electrical stimulus. It allows the therapeutic brain effects without the dangerous physical manifestations.
Okay, big shift now. We're moving away from drugs that cause paralysis at the NMJ to drugs that aim to reduce muscle tone or spasm, acting either directly on the muscle itself or within the central nervous system. Let's start with a unique one acting directly on muscle, dantrolene.
Dantrolene is completely different from everything we've discussed. Chemically distinct, pharmacologically unique. It doesn't block the NMJ, doesn't affect nerve conduction, doesn't block the muscle action potential itself. It works later in the process.
Specifically where? What's its target inside the muscle cell?
It targets the ryanodine receptor, specifically the RRR1 isoform, which is a calcium channel located in the sarcoplasmic reticulum, the muscle cell's internal calcium store. Normally, the muscle action potential triggers a small influx of calcium, which then binds to the RIR1 receptor, causing a massive release of stored calcium from the SR. That's called calcium-induced calcium release, and it's what initiates contraction. Dantrolene interferes with this process. It binds to the RIR1 receptor and reduces that release of calcium from the SR. It effectively uncouples the electrical excitation signal from the mechanical contraction.
That unique mechanism gives it two very different, very important uses.
Right. Taken orally, it's used chronically to reduce spasticity, that excessive muscle tone and stiffness seen in conditions like multiple sclerosis, spinal cord injury, cerebral palsy, stroke. It directly reduces the force of contraction. The major downside here is that because it weakens all skeletal muscle contraction, it causes significant muscle weakness. This often limits its usefulness, especially for patients trying to walk or maintain function. It's a trade-off.
And its other use, the life-saving one.
It is the only specific antidote, the drug of choice, for malignant hyperthermia. MH is essentially a runaway calcium release from the SR, triggered by anesthetics in susceptible individuals, causing intense muscle rigidity, heat production, metabolic chaos. Dantrolene directly targets that malfunctioning RYR1 calcium channel, stops the excessive calcium leak, and allows the body to cool down and recover. Given hard ban, it's life-saving in that crisis.
We should probably also quickly mention quinine here. It's listed separately.
Yeah, quinine is mentioned sometimes. Its mechanism is different again. It seems to increase the refractory period of the motor end plate, making it less responsive to appetitive stimulation. Its main, though often debated, use is for preventing or treating nocturnal leg cramps. Not really in the same league as dantrolene for major spasticity. Hashtag tag 4.2, centrally acting muscle relaxants. Curare-derived. Okay, now let's move to the centrally acting muscle relaxants, the curare-derived. These all work within the CNS brain and spinal cord. Their goal is to reduce muscle tone and spasm by damping down excessive nerve signaling within specific pathways.
And you mentioned they target polysynaptic reflexes. What does that mean exactly?
Okay, so a simple reflex, like the knee jerk, is monosynaptic. Sensory neuron connects directly to motor neuron. Bang, done.
Yeah.
Polysynaptic reflexes are more complex. They involve one or more intermediary neurons, called interneurons, between the sensory input and the motor output. These interneuronal circuits are crucial for regulating ongoing muscle tone, coordinating movement, and preventing excessive muscle contraction. Cameras selectively depress the transmission within these polysynaptic pathways, especially in the spinal cord, more than they affect the simple monosynaptic reflexes.
And the crucial difference from NMBs is they reduce tone without causing paralysis. They leave voluntary control intact.
That's the goal, yes. To reduce involuntary spasm or excessive tone while preserving voluntary strength as much as possible. Essential for treating chronic conditions where the patient needs to remain functional. The unavoidable downside is that the CNS pathways controlling muscle tone are linked to pathways controlling alertness. So all cameras cause some degree of sedation or CNS depression as a side effect.
The first group developed was the mefenecin-like drugs.
Right. Mefenecin itself was the prototype back in the day. It seemed to work by blocking those spinal interneurons. But it had issues, gastric irritation, risk of phlebitis if given IV so it's not used. Its relatives, though drugs like carisoprodol, chlorzoxazone, methocarbamol are still around. They're mainly used for acute musculoskeletal conditions like muscle strains or spasms from injury, often formulated in combination with analgesics like NSAIDs or acetaminophen.
But their actual effectiveness for muscle relaxation, beyond just making you sleepy, it's often debated, isn't it?
That's fair to say. The sedation they cause might be a large part of their perceived benefit for acute pain. They tend to cause significant drowsiness and dizziness, and they aren't really effective for the kind of severe chronic spasticity you see in neurological diseases. For that, you need more targeted agents. Hashtag tag 4.3 advanced cameras and specific receptors.
Okay, moving to the more modern cameras that hit specific neurotransmitter systems. Diazepam is the classic example.
Diazepam, yes. The prototype benzodiazepine. It works by enhancing the effects of GABA, the main inhibitory neurotransmitter in the CNS. Specifically, it binds to a site on the GABA-A receptor complex. The GABA-A receptor is an ion channel that lets chloride ions into the neuron. When GABA binds, the channel opens, chloride flows in, making the neuron more negative inside, hyperpolarized, and thus harder to excite. Diazepam makes this GABA effect stronger.
So it boosts the body's own calm-down signals in the CNS.
Essentially, yes. A lot of its muscle relaxant effect seems to come from actions higher up in the brain, not just the spinal cord. The clinical issue is its therapeutic window for muscle relaxation isn't great. You often get significant sedation before you get profound muscle relaxation. Still, it's very useful for acute muscle spasms, certain types of spasticity, anxiety-related muscle tension, and it's a mainstay for treating the severe spasms of tetanus, usually given IV.
But for chronic spasticity, say from MS or spinal injury, baclofen is often preferred. Different target.
Completely different target. Baclofen is a selective agonist for the GABA B receptor. This is crucial. Unlike GABA A, which is an ion channel, GABA B is a G protein-coupled receptor, GPCR. Activating GABA B receptors does two main things. It opens potassium channels, letting positive charge out, also hyperpolarizing the neuron, and it closes calcium channels, reducing neurotransmitter release from nerve terminals.
How does hitting GABA B instead of GABA A change the clinical effect compared to diazepam?
Baclofen seems to act primarily at the spinal cord level, depressing both polysynaptic and monosynaptic reflexes by reducing the release of excitatory neurotransmitters like glutamate. It generally produces significant reduction in spasticity with less sedation compared to diazepam at effective doses. This makes it a preferred drug for managing spasticity of multiple sclerosis, spinal cord lesions, and ALS. Important note, it's generally not very effective for spasticity caused by stroke or cerebral palsy. And a major warning with baclofen, you absolutely cannot stop it abruptly after chronic use. Sudden withdrawal can cause severe rebound spasticity, hallucinations, confusion, seizures. It needs to be tapered slowly.
Okay, another approach. Tizanidine. This one targets the adrenergic system.
Yes, tizanidine is structurally related to clonidine, an antihypertensive. It's a central alpha-2 adrenergic agonist. It works primarily in the spinal cord by binding to alpha-2 receptors on presynaptic nerve terminals. This inhibits the release of excitatory amino acids like glutamate from spinal interneurons, effectively damping down the signals that cause excessive muscle tone. A potential advantage of tizanidine is that it might reduce spasticity with less associated muscle weakness compared to baclofen or dantrolene. Its efficacy is generally considered similar to baclofen and diazepam, offering another good option. Need to monitor liver function, though.
And one more listed, thiocolchicoside.
Thiocolchicoside. Chemically related to colchicine, used for gout. Its mechanism isn't perfectly clear, but it's thought to have some GABA mimetic and possibly glycinergic activity. Glycine is another inhibitory neurotransmitter in the spinal cord. Its use seems mostly limited to treating acute painful muscle contractures, like neck stiffness, torticollis, or low back pain, usually short-term and often combined with NSAIDs. Hashtag 4.4 final uses of cameras. So let's just pull it all together. Where do these cameras fit? For acute muscle spasms, think pulled muscle. Acute back pain, you might use the mefenazine-like drugs, curacil, methocarbamol, or diazepam, usually short-term, along with pain relief, accepting the sedation.
But for the serious chronic spasticity from neurological disease.
That's where the heavy hitters come in. Baclofen, tizanidine, and diazepam are the mainstays for managing spasticity in MS, spinal cord injury. Dantrolene is also an option, especially if other agents fail, but you have the weakness and liver toxicity concerns with long-term use. The mefenazine group is basically ineffective here.
Tetanus with its life-threatening rigidity.
IV diazepam is usually the first-line treatment, titrated carefully to control the spasms and rigidity. Sometimes IV methocarbamol is used too.
And maybe for helping with orthopedic procedures.
Yes, sometimes IV diazepam or methocarbamol might be used to provide muscle relaxation for things like setting fractures or reducing dislocated joints, especially if general anesthesia isn't required or desired.
Wow. Okay, we have covered an immense amount of ground today. From poison arrows in the Amazon to the incredibly specific molecular interactions at receptors, we really dug into that chemical difference, the bulky pachycurare, the competitive blockers like rocuronium versus the slender leptocurare like succinylcholine, which acts like a persistent ACE, and how that dictates everything, especially reversal.
And we hammered home the monitoring. Understanding fade with competitive blockers versus that sustained no-fade pattern in phase-I depolarizing block using the train of 4. That's non-negotiable knowledge that we shifted completely, looking at dantrolene hitting calcium release right in the muscle for MH, and the central agents like baclofen targeting GABA B, diazepam hitting GABA A, tizanidine on alpha-2 receptors, all trying to modulate tone, not just paralyze. And the clear trend in NMBs is towards drugs with cleaner profiles, right? Less histamine release, much better cardiovascular stability, cisatracurium's Hoffman elimination, rocuronium speed and stability, moving away from the risks of DTC or pancuronium.
Which brings us right back to succinylcholine. We know it's incredibly risky in certain patients. The hyperkalemia danger in burns, trauma, and nerve injuries is profound. And then there's the significant unpredictable risk of prolonged paralysis from pseudocholinesterase deficiency, something you can't easily test for in an emergency. Now we have rocuronium as a fast non-depolarizing alternative, and sugamatics to reverse it almost instantly. So here's the provocative thought for you to mull over. Given how common pseudocholinesterase deficiency is, and considering the hidden conditions that can cause dangerous receptor upregulation, things like undiagnosed neuropathies or even just chronic immobility in frail patients, are there specific clinical scenarios where perhaps the rocuronium-sugamatics combination should become the default standard for rapid sequence intubation, ethically or logistically overriding the traditional reliance on the faster but inherently riskier succinylcholine? When does the known risk profile of SDs become unacceptable, even for speed?
Something to definitely think about. Thank you for taking this incredibly detailed deep dive with us today, really aiming for that mastery level. Until next time, stay curious and stay informed.